Thank you very much for the opportunity to talk about pre-surgical evaluation in epilepsy. I understand that this is a topic that a lot of training neurosurgeon may not have a lot of exposure to, and this is quite a big topic, and I hope to, at the end of it, I can give you a kind of framework to think about pre-surgical evaluation. I have no conflict of interest to declare. Back in 2012, the UK, which has a population of 70 million people, has set up the Children Epilepsy Surgery Service, or CES. It essentially divides the country into 4 areas to deliver all of the pediatric epilepsy surgery. Each area is provided by a hospital or clusters of hospital, of which Birmingham is one of them, and this is the hospital that we work in. In our multidisciplinary team, we have 2 to 2 neurosurgeons doing epilepsy surgeries and 2 to 3 neurologists, neurophysiologists, neuropsychologists, and 3 neurophysiology scientists. Each year we discuss about 100 cases formally, and in terms of surgical activity, we do just under 100 cases a year. Of those, 25 will be resection, 10 hemispherotomy, less than 5 disconnection surgery of other types, about 15 SEEG insertions, and therefore also the explantation, and 25 VNSs. In the next 30 minutes, I'd like to talk to you a bit about the background of pre-surgical evaluation. Hopefully I could demystify some of the misconceptions that a lot of neurologists or perhaps surgeons have about the epilepsy surgery. I'll talk about the evolving concept of the epileptogenic focus. I'll highlight the important investigations that we use for pre-surgical evaluation and go through a management algorithm that is widely used internationally. First of all, what is the patient population we're talking about? Well, we're talking about children who have drug-resistant epilepsy, and this is defined by the International League Against Epilepsy as a failure of adequate trials of 2 tolerated, appropriately chosen, and used anti-epileptic drug schedules, whether as monotherapies or in combination, to achieve sustained seizure freedom. So what is the actual population of this group of patients? Well, about 1% of the entire population has epilepsy. Of these, about 1/3 of them are drug resistant. And of those who are drug resistant, about 1/3 of them can potentially benefit from some form of surgical intervention. So we're talking about quite a big number. Looking at some real numbers in the US and the UK, in the US, on average per year, there are 11 people per 100,000 who will be diagnosed with drug-resistant focal epilepsy, but only 1/9 of them actually receive any surgery. A similar figure is observed in the UK. So we could conclude that epilepsy surgery is an underutilized modality to treat epilepsy. Why is that? Well, a lot of it is down to the common misconceptions held by some neurologists or pediatricians or the family. One of them is that all drugs need to be tried and neurosurgery is the last resort for treating epilepsy. Well, we know that after the first 2 drugs have failed, the chance of any reasonable and meaningful epilepsy control on the 3rd, 4th, and subsequent drugs are diminishingly low, of less than 10%. And in fact, in some cases, surgery should not be the last resort, but perhaps one of the first things that you should think of for treating epilepsy. For example, a low-grade tumor in a non-eloquent area. Many believe that bilateral interictal EEG spikes are a contraindication for epilepsy surgery, but in fact, we know that a lot of unilateral seizure onsets commonly have bilateral spikes as well. Again, a lot of people think that normal MRI is a contraindication. Well, epilepsy surgery was done even before MRI was invented. And in fact, current technologies and techniques allow us to detect single epileptogenic zone in these patients, and therefore we could treat MRI negative patients. Finally, people think that surgery is not possible if the eloquent cortex is involved. Yes, some epilepsy surgery will give patients some form of neurological deficits. However, the risk-benefit ratio should be individually evaluated before a decision to go ahead with surgery or not should be decided. Other deterrents to epilepsy surgery include fear from the family, the expense, depending on which country the patient is in, and also the reservations about the benefits. A lot of studies have shown that epilepsy surgery is safe and cost-effective, and we also have to remember that epilepsy syndrome is not just about the seizures. Very often the children could have neurodevelopment, social impairment, neuropsychological and psychiatric issues, and also they have the added morbidity and mortality associated with seizures, as simple as having a fall during a seizure attack and breaking a bone, to sudden onset, sudden unexpected death from epilepsy or SUDEP. And if the epilepsy surgery can cure the seizure, it will also have lead to improvement in all these domains. Not to mention the possibility of weaning off the anti-epileptic drugs, which has its own side effects. We're going to go through some concepts of epileptogenic focus now. Back in the 50s, Dr. Rasmussen will be doing a craniotomy and removing a macroscopically abnormal brain to cure epilepsy. What he finds is that if he also removes the surrounding brain, which also has abnormal discharge, the patients tend to have better seizure control afterwards. And he's come up with this kind of model where there is a lesion in the center, which causes the surrounding brain to be epileptogenic focused, and the seizure spreads outwards. This is a very neat model, but unfortunately the picture is actually a bit more complex than that. In the 90s, Luders have come up with the concept of epileptogenic zone, which is the area of cortex that is necessary and sufficient for initiating seizures and whose removal or disconnection is necessary for complete abolition of seizures. To date, we don't have a clear and definite biomarker of the epileptogenic zone. It is a concept. We do have other zones that we could map that approximate the epileptogenic zone. I'll go through this one by one. So, for example, if in this case, the epileptogenic lesion would be what you could see on an MRI scan. The irritative zone will be the area mapped by a scalp EEG where there is abnormal discharge in between seizures. The symptomatic zone will be the area which will be responsible for the seizure semiology at the beginning of an attack. For example, if the first symptom is jerking of the right upper limb, then the symptomatic zone will be in the left M1 cortex. The ictal onset zone is the area of the brain that has abnormal EEG at the onset of the operation of the seizure. The functional deficit zone is the area with abnormal brain function during the interictal states. For example, poor memory in a child with a temporal seizure. And we must not forget that beyond the epileptogenic zone, there is the wider ictal network, which involves the normal brain and normal brain neurons. On the right, I have put a few boxes which indicate the common investigation that we use in our presurgical assessment. which are used to map the corresponding zones. Here I've got MRI here, EEG spikes, PET, icto-EEG, and these dots are SEEG, seizure onset zones. It's clear that although these zones overlap, they are not exactly the same. So even if we've mapped all these zones out, we still need to make a decision as a team and as a surgeon, which part of the brain to resect or disconnect to achieve seizure freedom. And to complicate matters even more, we are moving towards away from just a lesion concept in epilepsy, but more of a network problem. In this table, I've listed the zones that I've described up here on the top row, and the common investigations on the column here, from the most basic investigations like semiology, MRI, and EEG, to the more resource-intense and sophisticated modality like ictospect. It's interesting to show that actually, even if we just stick to the basic investigations, we have covered the main 5 zones quite adequately. So it's not unusual that the investigations will show abnormalities that are some of them overlapping and some of them not. And this provides us some information about the concordance of the several of the investigations. But we still have to decide then which is the area that is the most problematic and has the best chance of giving patients seizure freedom. The concept of the epileptogenic zone is very nice. It does have a few implications though. First of all, there is no direct preoperative measurement of the zone, which we've alluded to earlier. Removing the cortex causing the seizures is typically necessary, but not sufficient to achieve lasting seizure freedom. In other words, the epileptogenic zone often extends beyond the ictal onset zone. By definition, the epileptogenic zone is identified and confirmed retrospectively after surgery, which in a way is not much use in terms of presurgical evaluation. And again, it is based around an epileptogenic pathology or lesion, but as I said earlier, as you move towards a concept of a network problem, we may have to rethink this concept. This is the algorithm suggested by the International League Against Epilepsy, or ILAE, in working up a patient for epilepsy operation. It is quite busy, but actually to break it down, there is the first phase, which is the non-invasive investigation. The bare minimum one must do is an MRI scan, video scalp EEG, and neuropsychological assessment. What the organization has suggested also on both sides are complementary investigations, either to better localize the epileptogenic zone or to assess the risk of postoperative deficits. And it is these 2 areas which usually involve the more sophisticated investigations. After the first phase of non-invasive investigation, the patient may go straight to epilepsy surgery because they show enough concordance of the anatomical, clinical, and electrophysiological data. Or perhaps it's decided that they're not eligible for surgery because there is not enough a reasonable hypothesis about the localization of the epilepsy focus. Some of the patients do not belong to these 2 groups, but they require further investigation in terms of intracranial EEG recording, which is the phase 2 of the investigation. Again, after that, some patients will go for epilepsy surgery, and the others, because of risk involved or because of failure to localize the epileptogenic zone, is declined surgery. When I think about the working up of epilepsy patients, I think of to identify the part of the brain which causes the seizure, and therefore the parts that you need to resect, and the parts of the brain that carries important function like language and motor function, which tells you where not to resect, and also it limits your surgical resection. I'll talk about the first bit first. I think of the brain in 4 ways. First, the clinical signs that a problem exhibits, the electricity of the brain, the structure of the brain or the structure of the lesion of the brain, and the metabolism of the brain. And I'll go through them one by one. We've been doing this throughout our training and career. Clinical signs are important to tell us about the area of the brain that is not functioning. Where there's a change of brain function, it will exhibit certain symptoms, for example, in certain semiology in seizures, and in between seizures, there will be a specific or recognizable neurological or neuropsychological testing pattern that we can observe. So in the case of, so you can work backwards. So if somebody has a memory problem in a neuropsychology testing and the symptom semiology is automatism at the beginning, then you could work backward to deduce that the culprits of the seizure is coming from the temporal lobe. Moving on to electricity, EEG is the bread and butter of epilepsy workup. The most non-invasive technique is scalp electroencephalography, or EEG. It picks up the interictal epileptiform discharges. It is quick. It requires the patient to come in for half a day. It's non-invasive. However, it's limited by its spatial resolution, and it only picks up abnormality from the convexity of the cortex and not the deep structures. For some patients, in fact, for most of them, they will come in for video EEG or video telemetry. In such tests, the child is connected to the EEG machine and they are observed under the camera. The synchronized data are then used to analyze the seizures. It is very useful if the child has multiple seizure types, and you could actually marry together the semiology and the electrical physiology. It is very, very useful, and in fact, the only way to distinguish non-epileptic events from true epilepsy attacks. And it is very useful also to pick up seizure that occurs at sleep. For example, electrical status epilepticus during sleep, or ESIS. Moving on to the more invasive methods of EEG, Mr. Walsh will be talking to you a little bit more about serial EEG, but I'm just going to show a few pictures. This is the planning diagram by Telereck back in the 60s of depth electrode insertion. This is how we plan our depth electrode insertions currently using a software-assisted method. This is a bilateral implantation. This is the robot we use, and this is the post-implantation merged CT and MRI scan showing the electrode. Other invasive EEG methods are the subdural grid. This requires a craniotomy and a placement of the grid on the cortical surface. And the patient is then sent back to the ward for about 7 to 10 days, during which time data is collected. And with that data, the patient either go back to theatre after that period to have a resection of an identified epileptogenic zone, or that there is not a good enough surgical hypothesis, and therefore the grid is simply removed and the craniotomy closed up. It has the advantage over scalp EEG in that it has no artifacts caused by the intervening skull, and also there is a very good spatial resolution. The other way to get EEG from the brain surface will be intraoperative electrocorticography or ECG. In this case, the patient only go to theater once. The subdural strip or grid will be placed on the area of interest, and the surgeons will perform the resection guided by the iterative recordings from these strips. It has the disadvantage that as you are resecting the brain, you could irritate the surrounding brain area, and therefore give you a bit of a false positive of abnormal electrical discharge, and therefore it may overestimate the irritative zone. Magnetoencephalography, or MAG, is another way to study the electricity in the brain. EEG picks up the current well from the cortical surface, because the current usually travels down the pyramidal cells in this direction, and therefore it goes out of the skull radially. However, when you come to the sulcus, the current travels in this direction, which is parallel or tangential to the surface of the skull. However, the magnetic field that's associated with the currents is radial to the scalp surface, and this is better picked up by MAG. And this is a diagram to show the dipoles, the units of signals in this test where the epileptogenic focus is. The more newer development in terms of interpretation of EEG, especially those that are invasive, is the high frequency oscillation. These two EEG graphs come from the same data, but on the right, a filter has been applied to remove the lower frequency signal. And what you're left with are these little spikes here, which are called high frequency oscillations. It's been shown that these, the HFO, are highly indicative of the epileptogenic zone, and removal of these areas produce the best surgical outcome. Moving to structural imaging, we're all familiar with MRI. The epilepsy protocol usually consists of 5 to 6 sequences, including one that is perpendicular to the hippocampus for the radiologist to assess the volume of the hippocampus. A word of caution, during 6 months to 24 months of age, the child undergoes myelination, and during that time it is very difficult to pick up focal cortical dysplasia, and sometimes the scan has to be delayed beyond 24 months to make a definitive diagnosis radiologically for that pathology. The cause of epilepsy in children are quite different from adults, and I'm just going to show you a few examples. Whereas adults mostly have temporal sclerosis, in children you can have a low-grade tumor. Here, this is a pilocytic astrocytoma, a depth of sulcus, focal cortical dysplasia, a frontal polymicrogyria, a 1-year-old boy with a hemimegalencephaly, a young girl with a right MCA infarct, and a case of Rasmussen's encephalitis. I won't talk too much about more advanced imaging modality, but I'll just show you briefly what's at the horizon. Resting state fMRI is being increasingly used as a research tool, but it also may be useful in the future by comparing or measuring the activity of the brain whilst they're resting or when they're not performing a task. You could locate certain epilepsy-related activity. Also, by comparing the activity of different brain areas, you could construct some sort of connectivity map that connects different regions of the brain, and different connectivity pattern has prognostic value on what the surgical outcome may be. Moving on to metabolism, this is oxygen emission tomography. This is an area of hypometabolism during the interictal period, and it indicates an area of dysfunction. The PET scan area, the hypometabolism area, is often an overestimation of the area of the epileptogenic zone, but it is very, very useful in non-lesional cases to help lateralize and sometimes localize the seizure focus. SPECT is single proton emission CT. This is the scan done during seizure, and this is a scan done in between seizures. And when you subtract this image from this, you get an area of hypermetabolism in this area, indicating an area of seizure activity. Moving on to the functional side of investigation, remember these are the tests that tells you which part of the brain is eloquent and therefore should not, surgery should be avoided. The gold standard for lateralizing language is Wilder test, where an intracarotid injection of amylobarbital is done to anesthetize half the brain. During that time, some language and memory task is performed, and then we switch side and check on the other hemisphere. This investigation has been largely replaced by functional MRI, which has up to 90% sensitivity and specificity for lateralizing language. The language can also be mapped electrically. In this case, this child has SEEG insertion, and she's been asked to perform a verb generation task. And you can see that 2 or 3 of the electrodes consistently fire up when she's trying to perform this task. And therefore, we know that the contact points in these 2 electrodes are integrally involved in verb generation. We use diffusion tensor imaging tractography when we are doing certain operations where the lesion that we're removing is very close to the corticospinal tract and visceral tract to avoid the damage to these tissue. Finally, we also perform transcranial magnetic stimulation in our unit. Here you can see our scientists delivering transcranial pulses to this girl, and we're monitoring the small hand muscle movement here. Using this paradigm, we were able to map the hand area and the motor cortex, which correspond well to the anatomical description. Unfortunately, none of the tests or of most of the tests have been validated in terms of their efficacy, and it's very hard to compare their use. Also, a lot of it is dependent on local expertise. In fact, if you look at the agreement between experts about their feeling on which tests are useful and not useful in particular situation, there is a lot of disagreement. So in this table, down this column are the different etiology causing epilepsy, and across the top row here are some of the investigations that we have talked about with EEG, MRI, PET, ECOG, etc. The red boxes indicate that these experts have strong agreement that a test is useful or not. And as you go down the color of the rainbow, there is less and less agreement. Interestingly, EEG, video EEG and MRI continues to be the test that most experts agree on whether they are useful or not with these etiology. And then as you go to the more sophisticated investigation, there is increasing disagreement. I put up this a final evaluation protocol from the ILAE. It is an expansion of the previous flow diagram that I was showing you earlier. It has added a few other tests here which are etiology specific. What I want to emphasize with this protocol is that there is no one-size-fits-all preoperative surgical evaluation, and all of these tests should be individualized to particular patients. So the take-home message is pre-surgical evaluation is highly individualized and requires a multidisciplinary approach. And when we think about the evaluation, we should consider the clinical aspect, the electricity of the brain, the structural abnormality, and the metabolism. And we must not forget the eloquent functional area. Thank you.
George, I'll just get you back. There you go. George.
Oh, thank you, Naren. And thank you, Dr. Lowe. That was an excellent presentation. I think there's one question in the chat room. And the question is, in case you have focal epilepsy with focal activity on the video EEG concordant to the MR findings, such as the low grade or cortical dysplasia in a non-functional area of the brain, what would you recommend? Wait and see or surgery?
So, Vijay, Dr. Lowe, we'll just get your mic back. Will, can you put your mic back?
Yeah. Yes, very, very good question. It will all depend on the conversation between the epilepsy team and the patients and the family. And the two priorities are epilepsy control and also the management of an oncological problem. And oncological problem aside, which you can obviously watch and wait, I guess the factors one has to consider are the social ones as well. So, for example, would the person coming up to the age of learning to drive? Do they have problems with the anticonvulsant therapy they are having? Have they got side effects? What are the philosophy of the family? Do they believe in, well, if there is a surgical treatment, I would like to go for it? And all those come into play. And therefore, well, I'm not trying to avoid the question, but I think both observation and resection will be reasonable. In our units, in these cases where we think we have a good chance of over 85% of rendering someone seizure-free and stopping the anti-epileptic drugs, we will strongly recommend having a resection.
Excellent. Again, that was an excellent presentation by Dr. Lowe. Very clear, concise, and to the point. I guess the other question that I see in the chat room is the question is EEG localizing function in speech mapping. Can this be used in the theater? Again, I'm not, if you can look at that, I'm not sure what the exact question is. There's a couple of questions on stereo EEGs. We'll hold those until the next presentation so we can get a better understanding of the use of stereo EEG in pediatric epilepsy surgery.
Okay. So regarding the speech mapping, it's during operation, the only way to do that will be to do a wake craniotomy, and it certainly can be done, but obviously in a setting of a pediatric neurosurgery, it's difficult because you do require a strong compliance of the child. But yes, you could certainly demonstrate or elicit speech arrest during a awake craniotomy to localize speech area. A note of caution, children generally less than 10 years of age are very unlikely to cooperate in theater for awake craniotomy. So there is an age limit to this modality as well.
That was, well, thank you very much, Dr. Lowe. That was an excellent presentation.